Right. Hello, everyone, and welcome to yet another podcast from WinFocus World. My name is Adrian Wong. I'm a consultant in intensive care medicine and anesthesia in King's College London. I am joined by my friend and colleague, Professor Francesco Corradi, who is the editor of the Ultrasound Journal. And we have a very, very special guest with us this time around, and it is Mr. Simon Hayward. Simon, introduce yourself, please.
Hello, everybody, and thank you for the invitation. Like Adrian says, my name is Simon Hayward. I'm a physiotherapist by background, and I work in the northwest of England in a town called Blackpool. And basically, my passion is for a number of years, probably a decade now, has been lung ultrasound and diaphragm ultrasound.
Wonderful, Simon. Welcome. So, congratulations. Your manuscript, which has been accepted for publication in the Ultrasound Journal, is entitled Exploring the Adoption of Diaphragm and Lung Ultrasound by Physiotherapists, Physical Therapists, and Respiratory Therapists, an updated scoping review. So, congratulations. Why
Thank
don't
you.
you share with us the main headlines from your paper and manuscript then?
Awesome. So, like the title suggests, this was an updated scoping review. So I originally did one with the searches back in 2016 that was published in 2018. And over the intervening 7 years, I just saw a dramatic, from my perspective, a dramatic increase in the number of publications that were being released by physiotherapists and our kind of similar therapy colleagues in other parts of the world, because there is a difference in the terminology and the scope of practice, but very, very large areas of overlap within these therapist professions, shall we say, within lung and diaphragm. So I thought it would be rather timely to do an update of that scoping review to cover more of the professions that alluded to in the title, but also just to kind of begin to show the wide breadth and use of diaphragm and lung ultrasound within our respective professions, because it just seems to be going up and up and up and up. So that's exactly what my co-authors and I did. Basically, there's quite a bit of difference between the professions with regards to scope of practice and autonomy. So different areas of the country, different areas of the globe, the professions have different degrees of autonomy about how they can scan, whether they can scan at all. So I just wanted to lay out a really clear map of exactly what has come already for these various professions, for physiotherapy particularly being my background, to show the huge scope, breadth of population, of pathologies, of uses, whether that's education, clinical, or within the research realm, of exactly what is going on with this ultrasound techniques within
Okay.
physiotherapy and others.
Okay. Wonderful. And we're going to take a bit of time to dissect down to the details of it. But Francesco, as a avid fan of ultrasound, especially lung ultrasound, and your thoughts as the journal editor, why is this paper so important?
Because the manuscript addressed another piece of the puzzle that was lacking until now. Indeed, the last 7 to 8 years, the overall number of manuscripts performed by or involving respiratory physiotherapists or respiratory physicians tripled, or even the overall number of manuscripts in up to five times. And this is very important. And the other point is that is now clear, at least to me, by reading the manuscript, that up to now, physiotherapists for the first time embrace ultrasonography and perform ultrasonography by themselves, and are not relying anymore on other imaging professionals like radiologists in order to assess the respiratory management of the patients. And this is very important to me because it seems to ask chest ultrasonography or lung ultrasonography, whatever you want, for a respiratory physician seems like to an intensivist to ask for lung ultrasonography before perform a chest tube drainage or in order to assess an infusion. And because we know that the core business of point of care ultrasonography and the strength on the methods is when the method itself is performed by the physician in charge or the professional in charge to the patient. So this is a big step forward, and obviously highlights the strength of this rise, and also some pitfalls concerning some tender points, because we know that the everyday increasing number of manuscript and attention accounts mainly for high income countries, but on the contrary, probably middle to low income countries can benefit mostly by point of care ultrasounds in the assessment of everyday clinical round.
Okay, so 100% agree with everything that you said, Francesco. I think I'm really lucky because I'm in the same country as Simon. Physiotherapists performing lung ultrasonography, at least in the UK, is not completely abnormal. It's becoming more common. I wish it was more common, but it's getting there. Now, Simon, then over to you as a physiotherapist, as someone who's really championed the course of lung ultrasound amongst physiotherapists in the UK, if not internationally. What did you tell us a bit more about the differences in clinical utility? How are physiotherapists using lung ultrasound these days? And tell us about the difference between one country to the next country, having done the systematic review and literature search.
So I know if I talk about physiotherapy profession specifically, now we can broaden that a little bit to include respiratory physiotherapy, which is still the same profession, but we kind of specialize in the respiratory disciplines, versus a physical therapist, typically from the United States, or a respiratory therapist, again from the United States. It's these slightly different terms, and the scope and the training is different. Now, like I mentioned before, there is a lot of overlap, and there's going to be a lot of ways that each of these professions can use point of care ultrasound, diaphragm, and lung for their own practice. Autonomy across the globe is very different. So in the United Kingdom, in some of the Scandinavian countries, in the Republic of Ireland, physiotherapists have a huge degree of autonomy. Even within the United Kingdom, that we can go on to do non-medical prescribing. So we can prescribe medication, we can use diagnostic imaging techniques, we can order diagnostic imaging techniques with the right background training. Whereas in other places, whether it's high-income countries, even within Europe, where physiotherapists still cannot use any form of diagnostic ultrasound at all, or middle, low-income countries where the physician rules everything. Your gateway to any sort of imaging is through the physicians, is through the doctors. So part of this scoping review, and again, Francesco alluded to it, is the importance to me to allow other individuals around the world to kind of see what is going on within their own profession, whether that country has the autonomy or not. With the, hopefully, eventually one day, the idea that they may be able to use these diagnostic techniques, these imaging techniques, to kind of inform their practice without relying on our medical colleagues for every instance that we want to do that. So it was very important for me to kind of showcase what can be achieved to my fellow colleagues, to showcase what one profession is doing versus another profession, physiotherapists versus respiratory therapists, but also people within countries that don't have the autonomy, perhaps what they can strive towards.
Francesco is actively making notes on his keyboard, I'm sure, because my next question to Francesco is that, Francesco, tell me about what happens in in your part of the world, what can your physiotherapist perform lung ultrasound, or can Italians physiotherapists, respiratory therapists perform lung ultrasound, or is that not a thing?
Usually not, but times are changing, and they want to learn lung ultrasounds. Usually what happens that in my ICU, I changed several ICU, and I start working with nurses and with respiratory physiotherapists in order to allow them to perform lung muscle ultrasonography and whatever you want, because I think that they are professionals. They work side by side with us, and they need to have their own autonomy, because they are the best professional concerning their job. So I think it's very important to assess the patients by themselves, and not relying only on gas exchange or asking the physician what is going on. I think that they should probably, I would say, my feeling is that they must learn lung ultrasonography in order to help the physicians to do better his jobs.
Okay. Well, so I sort of knew you were going to say that, Francesco. Okay. But before we go on to the very, very important aspect of training such colleagues, Simon, you've already mentioned that there are colleagues out there in your professional group, company, community, if you will, who are unable to perform lung ultrasound for a variety of different reasons. So just to give them a bit of a flavor then, why don't you describe your average day? Obviously include some lung ultrasound into it. Your average day in the life of Simon Haywood at work then.
So going back to the kind of the grassroots a little bit, and like Francesco said, all I want as a health professional to help my patients is a really good, accurate way to identify pathologies I might be dealing with. I want a really good source of information to guide what I'm going to do as a therapist. And I want accurate information to make those clinical decisions with my clinical reasoning. And I want an effective way to monitor exactly what's going on when I do something, like any professional would. What is the impact of my interventions? And then the wider picture, the outcome for the patient, and the kind of our research evidence base. So that's kind of what I've been pushing this whole time. So for me, it involves my clinical practice is a lot less these days. So I do a lot more of the teaching and the research personally. But absolutely, we'd go do the ward rounds, get the handovers in the morning, and go around and do that sort of baseline kind of planning out the day. But then each individual patient, depending on the indications, with regards to the physiotherapy practice, using ultrasound to inform those decisions, kind of getting the baseline metrics for that patient for that given day. It might be a new admission, it might be an ongoing long-term patient, and building up that additional pieces of the jigsaw with regards to what's going on with that patient's clinical history. So it would be going in and doing the lung ultrasound, evaluating the diaphragm, and using that information to make clinical judgments about whether what we did the day before worked, what we're going to do that day, and then using that information into the clinical picture to make those decisions and feeding back to the team. So absolutely, you could, as a both of you being physicians, you could use your physiotherapy team to support that scanning, to give you that information. They may well know the patients very, very well. From my perspective, sometimes the physiotherapists can be somebody that has been seeing the patient every single day, potentially for weeks on end, we don't necessarily always have the same shift patterns as nurses or doctors, where you're on call and then you're off doing other things for another week. So sometimes we are that consistency that you can have through your patient's journey. And if we have that consistency of contact with the patient and a very powerful tool in point of care ultrasound, obviously in this case, diaphragm and lung ultrasound, we can give you some very, very accurate and identify very subtle changes in the patient that may or may not be relevant.
Is there, I mean, thinking back now, because you started this journey over a decade ago, is there a particular type of patient group that you think, my God, I can't imagine looking after this patient, this type of patient now, if I didn't have lung ultrasound, diaphragm ultrasound?
There's so many. Interestingly, I've just completed a national survey of all the nearly 250 physios in the UK that have gained their lung ultrasound accreditation. And I've got responses from nearly 170 of them. So I've got this massive list of indications of why physios specifically want to do lung ultrasound in this particular
What's
case.
your number one, though?
My number one, I think an absolute given, critical care has been my background. Various types of critical care. But for me, as a physiotherapist, and one of the big reasons we're employed would be to very, very quickly and accurately identify post-operative complications, pulmonary complications. So very, very quick, very, very easy. Is it collapse as a result of the anesthesia and the ventilation and non-recruitment, or is it an effusion and an infection building in? Very, very quick to tease that apart within the clinical picture. So as a respiratory physiotherapist, one of my main jobs is to keep the chest clear, keep the lungs recruited, and lung ultrasound with elements of diaphragm ultrasound can help me do that very, very quickly indeed.
Thanks. Francesco, any thoughts on, if you had a team of ultrasound capable physiotherapists, respiratory therapists, how are you going to utilize them in your unit?
I think that we can manage the same patients with in different moments, and this is important because I'm not pro as a respiratory physiotherapist. Okay, it's not my job. The most of information, insights we can achieve by ultrasonography are dynamic in the means that change over time. So if we want to plan a strategy in order to win the patients, probably we can have some different strategies to run. And by looking for what is going on, we can choose one way of winning or another. For example, I know that the respiratory physiotherapist in awake patients starts when the patient is still submitted to orotracheal intubation during pressure support ventilation. No? So probably what we want to know is how is the workload of the respiratory muscles, and if I can extubate the patient, yes, probably I can extubate the patient, but the question to be answered together from the intensivist and the respiratory physiotherapist is the patients will be reintubated or not, what is and how is distributed the workload of the respiratory muscles, meaning the accessory inspiratory, expiratory, and the diaphragm. And probably the overall workload will rely, at least in part, on the lung parenchymal assessment. And the lung parenchymal assessment will probably may be different at the beginning of the weaning or at the end of the weaning or at the end of the respiratory therapies. I mean, there are some questions that can be answered only by the respiratory therapist or physiotherapist, and to do it better, I think that lung, muscle ultrasonography, and in my opinion, also a limited point of care heart ultrasonography can be useful in order to address and answer my questions. So I don't know if I answer your
No,
questions.
I think the both of you have very very passionately made the point that you both think. I'll put myself in that group as well. That our physiotherapists, physical therapy colleagues should, and respiratory therapy colleagues should perform lung ultrasound. I hope people are listening to this and will be inspired to do it. And then it comes to the next key question: how are they going to learn? How are they going to train to become competent in it? Because it is a tool, it's a practical skill at the end of the day. So you're going to need to learn it. So, Simon, insights, maybe some personal experience in terms of how do you get a colleague who has been convinced to become competent in lung diaphragmatic ultrasound?
Despite first being introduced to lung ultrasound, like I said, over a decade ago, very, very quickly, the first question was, how can I learn this technique? How can I do it myself? So fortunately, within the UK, there was there was the mechanism to do that through our intensive care society. And there are other societies that you can do it in the UK. So a lot of my work since training in myself and using it clinically, and hence why I've stepped into less clinical work, was to basically lay the foundations for as many people in the United Kingdom as possible and further afield to be able to pick up the probe and start to scan themselves. So a lot of my research work since then has been, your typical barriers, your implementation strategies, your guidance, governance documents, and guidance on about how to do these sorts of things. So that has been the main focus of my work in the last 5 years, at least, and will continue. Basically, it was that kind of old adage of teach a man to fish, he'll fish for a day. Give a man a fish, he'll eat for a day. Teach the man to fish, and he'll eat
You know what
forever.
you mean?
Yeah, I may have got that slightly wrong, but basically, my main focus has been to kind of build up the number of physiotherapists that have learnt and can do the technique, and that has involved a huge amount of mentorship on my part. So you obviously do the training program, and then you need the mentorship to make sure you're really embedding that in the clinical practice, and you have the skills, the confidence, and the competence, and the capability to learn the technique. So I've spent a lot of time moving around, traveling, supporting my physiotherapy colleagues, trying to be strategic about it around the UK, kind of picking certain individuals to kind of upskill to then help the region. Yeah.
But you're clearly talking about something sort of the higher level considerations, the policies, etc., etc. But let's go down to the nitty gritty of someone. So someone wants to learn how to do lung ultrasound. Broadly speaking, why don't you give a description of what happens in the UK then? Someone in your hospital. They'll make it easy for you. Someone in your hospital wants to learn how to do lung ultrasound from D. Simon Hayward. How is it going to happen?
So the first step would be to usually register with a society that has a training program, and then you get access to all their resources, and then attend an introductory course. So this is usually, depending on the size of the course, typically 1 day for lung ultrasounds. Courses I've run elsewhere have been a couple of days to then incorporate diaphragm ultrasound as well. And then after that introductory course, you're then spending some time, hopefully, ideally, initially one-to-one with a mentor, somebody more experienced who is approved and has the knowledge to be able to teach you. And that training is done at the bedside, maybe initially with some volunteers, maybe colleagues, but then definitely with patients as you begin to expand your experience with regards to different types of patients, whether that's the physical differences of individual patients, let alone the pathologies and the mechanisms and the clinical histories that you're dealing with. So you have the initial training and then mentorship as you go through. And then eventually that process becomes less and less direct mentorship and supervision, and you transition away until you reach a level as deemed by the training pathway you follow and your mentor as to when they feel you're ready to go through some sort of assessment mechanism at the end of that process to make sure you're at a decent enough level, at the very least, to carry on and go on learning, as we all do with point of care ultrasound. That continues. So it's access to that mentorship, that training program, and then the mentorship, which is absolutely crucial. So the more individuals we have trained up, and this is the high level you were alluding to for physiotherapists and physio specific mentorship. It is different when we learn from our medical colleagues, but when you're trained as a physiotherapist, learning lung ultrasound from another trained physiotherapist, that really picks up the nuances of what's going on with your clinical reasoning processes. So my goal was to build up the mentorship so that others could follow in the footsteps and be able to learn the
Okay.
techniques.
I mean, you described the process very, very nicely. Some form of course to get your knowledge and core skills up, get some idea in terms of what a scan actually involves, some supervised mentorship time with an expert to build up your confidence, to build up your knowledge, both from a theoretical standpoint, but also, the practical standpoint of it. That involves probably gaining a number of cases under your belt with a logbook of some form, and then ultimately at the end there's some form of assessment. But we never stop learning, so an assessment is just is a gateway to the next step. Francesco, then, on your thoughts on training our physiotherapy, respiratory therapy, and physical therapy colleagues on lung ultrasound, and maybe do you run a course already specifically at this for this group of colleagues?
Yes, from my perspective, a training course for respiratory physiotherapist, respiratory therapist, and physical therapist is lacking, basically. And this is the first consideration, the basic consideration that move to plan a course for them. How, what the characteristics? So I think that it's very, very important to have involved in the faculty physiotherapist, physical therapist, and respiratory therapist skilled in ultrasonography. This is my basic point. Indeed, in the course we are releasing, we focus physiotherapists will be faculty member. The second point is that what I learned from other ultrasound course, I think it's important since the very beginning to try to start with simulations and to put ultrasonography into their clinical practice. So not to teach them ultrasonography, if you want, or lung ultrasound or whatever, but try to put ultrasound into daily clinical practice performed by physiotherapists. That basically means that since the very beginning, you need to assess lung parenchyma by lung ultrasounds. You need to assess respiratory accessory muscles and diaphragm, and something concerning the heart. I think it's quite important. So, from my perspective, an ultrasound course for this kind of professional, ultrasonography is important, is the core, but everything surrounding the course, turning around the course, is even more important. I mean, at the end of the course, you as a respiratory physiotherapist, you don't have to know where come from B lines. You have to know how to use ultrasonography in order to set positive pressure support in NIV ventilation. How to, I don't want to say set the best PEEP, but to avoid overdistension, or how to change the proper tool between high flow nasal cannula, CPAP, or pressure support ventilation, depending on the journey of the patients that may be changed because develop fever or whatever you want. So I think this represents the basic point that we want. So it's an integration between mechanical ventilation and ultrasonography. Also, making very, very clear that represent a very useful adding tool to use with respiratory compliance and with all the other clinical parameters. But I think we need a specific program design. And the last but not least, mentorship for sure. But we need a respiratory physiotherapist as a mentor, and not physicians, nurses.
That's a very, very good point, and I think I'm reflecting on our practice. So, like both of you, I trained lots of colleagues in lung ultrasound and some physiotherapists with that. But I'm just reflecting on the way I teach them as a consultant in intensive care, as opposed to Simon would teach them. I think the basics are there. The basic. This is how you hold a probe. This is how you get the image. This is how you optimize the image. They're all there. I always emphasize that when it comes to point of care ultrasound, the learning curve it was almost in 3 phases. Image acquisition, can you get the image? Image interpretation, what does the image show? And finally, the last bit, which is often the most important bit, clinical integration. How do you put it into the clinical context for the patient in front of you? And I am just reflecting on the fact that my clinical integration approach to X is obviously from a consultant in intensive care perspective, as opposed to a physiotherapy colleague perspective. So both you and Francesco have made me think about my own practice in terms of as a mentor, as a trainer, in terms of that. I'm sure lots of our listeners will now just hopefully be inspired, whether they're already teaching colleagues or not. And if you're a physiotherapist, physical therapist, or respiratory therapist, I hope you've given you a bit of a taster in terms of what to expect. So thank you very much, Francesco. Thank you very much, Simon, for joining us. I'm sure we'll be keeping in touch, and I look forward to your next piece of work. Thank you, everyone.
Thank you very much.